Welcome to Inside Pediatrics with Dr. Chadia Jbeily, pediatrician with medical training from St. Joseph University in Beirut and Université Paris-Cité in France. In episode 2, we will explore the allergic reactions. What are the underlying mechanisms and prevalence of allergy?
The immune system is a finely tuned defense network. Its role is to eliminate harmful pathogens while remaining tolerant to harmless substances such as allergens. Regulatory T lymphocytes play a key role in maintaining this tolerance by suppressing unnecessary immune responses. In allergic conditions, both the number and function of these regulatory T cells are reduced, leading to a loss of immune tolerance. This imbalance is often associated with a genetic predisposition known as atopy and is further influenced by the environment. Allergic diseases are highly prevalent worldwide. Asthma affects about 300 million people globally, and 30% of cases are severe. Allergic rhinitis, 400 million, with prevalence exceeding 40% among children. Urticaria, 66 million people, and may be acute or chronic, often triggered by the environment. Atopic dermatitis typically begins in infancy or early childhood and affects about 20% of children. Food allergies, 8%. Allergic diseases may begin in infancy or childhood, but they can also develop later in life.
Second question. What are the phases of the allergic response?
The allergic response occurs in two main phases. The first phase is the sensitization phase. When the body encounters an allergen for the first time, it's detected by sentinel immune cells, mainly dendritic cells. These cells capture the allergen, process it, and migrate to nearby lymph nodes. There, they activate B lymphocytes, which begin producing allergen-specific immunoglobulin E, IgE antibodies. The IgE antibodies circulate in the bloodstream and bind to high-affinity IgE receptors on mast cells in tissues and basophils in the blood. At this stage, the person is sensitized but has no clinical symptoms. The second phase is the clinical or effector phase. Upon re-exposure to the same allergen, the allergen cross-links the IgE molecules bound to mast cells and basophils, triggering immediate degranulation. These cells release histamine and other mediators such as tryptase, prostaglandins, and leukotriene. Histamine causes vasodilatation, increased vascular permeability, bronchoconstriction, and pruritus. This immediate hypersensitivity reaction typically occurs within 10 to 20 minutes and may present as urticaria, angioedema, bronchospasm, or in severe cases, anaphylactic shock. 4 to 6 hours later, a late phase reaction may develop, characterized by the recruitment of Th2 lymphocytes and eosinophils, leading to sustained inflammation and contributing to chronic allergy conditions such as asthma and allergic rhinitis.
Third question. Which allergens are most commonly encountered, and what are the associated symptoms?
The most commonly encountered allergens can be grouped into airborne, food, drug, and insect allergens, each associated with specific clinical manifestations. Airborne allergens primarily cause allergic rhinitis and asthma. Allergic rhinitis typically presents with sneezing, nasal congestion or runny nose, postnasal drip, facial pressure, disturbed sleep, mouth breathing, fatigue, and the upward rubbing of the nose known as the allergic salute. Ocular symptoms such as itchy, red, watery eyes and eyelid swelling may also occur. Asthma manifests as cough, wheezing, and shortness of breath. Indoor allergens include house dust mites, Dermatophagoides pteronissinus and Dermatophagoides farinae, commonly found in mattresses, pillow, and carpets, especially in humid climates. Indoor molds such as Aspergillus and Penicillium, as well as animal dander, are also frequent triggers. Outdoor allergens mainly consist of pollens, including tree pollens, cypress, pine, olive, alder, birch, oak, maple, walnut, plane tree, grass pollens, Timothy grass, ryegrass, Bermuda grass, orchid grass, Parietaria, and molds such as Cladosporium and Alternaria. Birch pollen is strongly associated with cross-reactive food allergies, leading to oral allergy syndrome with raw apple, pear, peach, carrot, and celery. Food allergies commonly present with urticaria, angioedema, respiratory or gastrointestinal symptoms, and in severe cases, anaphylaxis. The most frequent food allergens include cow's milk, egg, peanuts, tree nuts, sesame, wheat, soy, fish, and shellfish. 50% of cow's milk allergy resolve by 1 year of age and up to 90% by 5 years. Most egg allergies resolve by school age. Tree nut allergy is more persistent, particularly walnut and pistachio, with strong cross-reactivity between walnut pecan and pistachio cajo. Insect venom allergy involves stings from Hymenoptera such as honeybees, wasps, hornets, yellow jackets, bumblebees, and fire ants. Drug allergy, especially penicillin allergy, is frequently overdiagnosed. Up to 90% of children labeled as penicillin allergic are not truly allergic, and sensitivity often wanes over time, with about 90% losing reactivity after 10 years.
Fourth question. How do we diagnose and manage allergic diseases?
Diagnosis of allergy begins with a detailed clinical history, the onset of symptoms, their nature, duration, triggering factors, and family history are essential, followed by a physical exam. Diagnostic tests support but do not replace the clinical history. Skin prick testing involves placing small amounts of allergens on the skin and pricking the surface. After 15 to 20 minutes, the wheal, swelling, and flare redness are measured. Intradermal tests involve injecting a small amount of allergen into the skin and are mainly used for drug or venom allergy. Patch testing is used to diagnose delayed hypersensitivity reactions, particularly contact dermatitis, with readings at 48 hours and sometimes later. Blood tests measuring allergen-specific IgE help identify sensitization to specific allergens. Provocation tests, such as oral food challenges, are performed under strict medical supervision and remain the gold standard for confirming food allergy. In asthma, lung function tests, such as spirometry, are used to assess airway obstruction and reversibility. It's important to remember that a positive skin test or specific IgE indicates sensitization, not necessarily clinical allergy. A diagnosis of allergy requires compatible symptoms occurring after exposure to the suspected allergen. Management focuses on symptom control and prevention. Non-sedating H1 antihistamines such as cetirizine or desloratadine are used for urticaria, allergic rhinitis, and conjunctivitis. Intranasal corticosteroids are first-line therapy for allergic rhinitis. Emollients and topical corticosteroids are essential in the management of eczema. In asthma, inhaled corticosteroids and beta-agonists are the cornerstone of treatment, with leukotriene receptor antagonists such as montelukast in selected cases. For severe or refractory disease, biologic therapies such as omalizumab or dupilumab may be indicated. Allergen-specific immunotherapy given subcutaneously or sublingually can be considered in selected patients with allergic rhinitis, conjunctivitis, asthma, and insect venom allergy.
Fifth question. How do we manage the moderate to severe allergic response?
Anaphylaxis is a severe life-threatening allergic reaction that affects at least 2 organ systems. The most common cause is food, followed by drugs, and then Hymenoptera venom. Symptoms usually begin within minutes to a few hours after exposure. If the symptoms include tingling in the mouth, swelling of the lips, itchy or watery eyes, runny nose, hives, or mild abdominal pain and nausea, the reaction is moderate. We give antihistamine and monitor the child until the symptoms disappear. Severe symptoms include voice changes, difficulty breathing, wheezing or coughing, severe abdominal pain, vomiting, dizziness, or fainting. It's important to note that isolated lip swelling or oral allergy syndrome alone is not anaphylaxis. Management is urgent. We lay the child flat or keep them sitting upright if breathing is difficult. Adrenaline is injected into the anterolateral thigh, 0.15 milligram for children under 30 kilos, 0.3 milligrams for children over 30 kilos, and 0.5 milligram for adolescents. Antihistamine, such as desloratadine, is given. Emergency services must be called immediately. If there is bronchospasm, we give salbutamol via spacer, 4 to 10 puffs, and repeat after 10 minutes if needed. If symptoms persist after 5 minutes, a second dose of adrenaline should be administered and the child observed for 4 to 8 hours. Upon discharge, we give an emergency kit including 2 adrenaline auto-injectors. Thank you for your attention. Take good care. Until next time.